This conference will now be recorded.
Hello, everyone. A warm welcome to one and all. Today, CM Dental Academy has organized for an oral pathology class. CM Dental Academy, it's an online dental education platform in the field of dental surgery. We aim at delivering excellent quality online training programs and courses for dental students under the guidance of eminent mentors. The subjects will be covered in all the formats such as live lectures, descriptive notes, MCQs, and Viva Voce questions. So, what are you waiting for? Come, let's begin a journey towards success. Orofacial region in general and oral cavity in particular contains both hard and soft tissues and may be affected by various pathological processes. These pathoses may be either congenital or acquired. Understanding the nature of the disease process is paramount in its diagnosis and management. Though the practice of dentistry depends majorly on technical skills, the sound knowledge of the structures in and around oral cavity in normal and pathological state is must. Today we are going to discuss about odontogenic keratocyst. Cyst is a common pathological lesion and occurs anywhere in the body. It is defined as pathological cavity, may or may not be lined by epithelium and containing fluid, semi-solid or gaseous material. Cysts are common in orofacial region and the most common cause for chronic jaw swellings. Cysts are broadly classified as odontogenic cysts and non-odontogenic cysts. Odontogenic cysts are further classified as developmental cysts and inflammatory cysts. Odontogenic keratocyst being the developmental cyst. The term odontogenic keratocyst was first time coined by Philipson in 1956. Later, the essential features of the lesions were described by Pinborg and Hansen in 1963. Why the term keratocyst was coined for this particular lesion? Because the lining epithelium of the cyst produces keratin that almost fills the entire cystic lumen. In 2005, the World Health Organization labeled OKC as keratocystic odontogenic tumor because of its aggressive behavior, recurrence pattern, and mutation in PTCH gene. It is nothing but a protein patched homolog 1 gene. However, this weave is reverted and in current classification, that is in 2017, again it is considered as a cyst and not as a tumor. The tissues of origin for this cyst being the remnants of the dental lamina. For any lesion in oral pathology or pathology, you have to describe the clinical features such as in which age it occurs commonly, the age of occurrence, peak incidence, in which decade of life the lesion occurs most commonly, the site or the predilection, site for predilection, whether it is maxilla, anterior mandible, or posterior part, like that you have to mention. So for odontogenic keratocyst, it occurs at any age from the very young to very elderly, but exceedingly rare under the age of 10 years. Peak incidence being the second and third decade of life. It has a male predilection. Inside, it is most commonly affects mandible. In mandible, ramus of the mandible, third molar area, first and second molar area, then anterior mandible. These occur occurrence of site in a descending order. In case of maxilla, it affects commonly the third molar area, followed by the cuspid region. There are no characteristic clinical manifestations of the keratosis. There are no any particular clinical manifestations so that patient will complain of. Only 50% of the patients are symptomatic. They complain of pain, soft tissue swelling, expansion of bone and drainage, various neurologic manifestations such as paresthesia of lips and teeth. Maxillary lesions have a tendency for secondary infection compared to the mandibular lesions because of its close proximity to the maxillary sinus. When we aspirate the material from the cystic lumen, the odontogenic keratocyst, it shows a cheesy material suggestive of a keratin. In a photograph, you can see the cystic aspirate. Sometimes it appears straw colored also. It has a protein content of 3.5%, which is a soluble protein. Odontogenic keratocyst presents few characteristic radiographic features such as unilocular radiolucency and multilocular radiolucency. The unilocular radiolucency presents with a well-defined peripheral limb and sometimes scalloping of the border is present. The multilocular radiolucent lesions generally present a central cavity having satellite cysts. When it is multilocular, and especially if located in mandibular third molar area, it may be confused radiographically with ameloblastoma because ameloblastoma occurs in the posterior mandible most commonly with the radiographic feature of multilocularity. Occasionally, the lesion may mimic dentigerous cyst if it contains crown of an unerupted or impacted tooth within its lumen. So these are the differential diagnosis radiographically. We have to rule out for it. Sometimes lesion tends to grow in anterior-posterior direction, resulting in large lesions, but clinically it might present as a small or no swelling with little cortical expansion. The direction of extension for this lesion being anterior-posterior direction. So clinically it may not show the obvious signs of like swelling or any growth like that, but it has already spread so much in anterior-posterior direction, it presents clinically with a small swelling. So the characteristic appearance of odontogenic keratocyst, here in an orthopantomograph, we can make out a scalloped border of the lesion in posterior mandibular region. And this is the computed tomographic picture of a mandible showing multiple ocases. Radiographically, odontogenic keratocyst presents four variants: a replacement type, envelopmental type, extraneous type, and collateral type. In replacement type, when the keratocyst develops in place of a developing normal tooth, it is called the replacement type. In such cases, there will be absence of normal tooth in the dental arch. In envelopmental type, cyst encloses an impacted tooth within bone. It is called envelopmental type of keratocyst. In extraneous type, keratocyst develops away from the tooth-bearing areas of the jaw. And in collateral type, the odontogenic keratocyst occurs in between the roots of the tooth. So it presents four variants radiographically. Final diagnosis of any cystic cavity within the jaw bones will be only after biopsy of the surgical specimen. 20% of the cases which show the multilocularity often tends to be more larger lesions when compared to unilocular lesions, which contributes to 40%. 30% of the maxillary lesions shows the buccal expansion, while that of 50% of mandibular lesions are associated with the buccal expansion. Mandibular lingual enlargement is occasionally seen. Proximity to the roots of adjacent normal teeth sometimes causes resorption of these roots, although displacement is more common. Instead of causing more of teeth resorption, it leads to the displacement of the teeth. Sometimes the cysts displace neurovascular bundles. Some atypical manifestations of the keratocyst. Other than these typical clinical features and the radiographic features, the odontogenic keratocyst shows some atypical manifestations such as an extra osseous form, which occurs outside the jaw, like involving the soft tissues. It is called as peripheral odontogenic keratocyst. It occurs mainly in gums, cheek tissue, and deep lateral facial region. One more variant which presents with pigmentation in young females with an average age of 18 years have been reported, where the pigmentation is due to the presence of melanocytes without atypical features within the squamous epithelium of the tumor. So these are the two variants, like an extra osseous form, which is called as peripheral odontogenic keratocyst, and cases of the pigmented odontogenic keratocyst. These are very common questions asked during the viva. Other variants of odontogenic keratocyst, radiographic variants of odontogenic keratocyst, who coined the term odontogenic keratocyst, why it is again reclassified as cyst and not as a tumor. So till now we are aware how it clinically presents, how it radiographically appears on the radiograph. But what causes the cyst formation? What is the mechanism involved behind the cyst formation? There are three phases in which it leads to the cystic formation. That one is there is a cell proliferation, after which there will be osmolarity of the cystic fluid. Further, there are enzymatic mechanisms. These are the three mechanisms which leads to the cyst formation in odontogenic keratocyst. In cell proliferation, as the odontogenic keratocyst is made up of preformative cells of dental lamina, they have an increased tendency for mitotic divisions. Increased mitotic activity of the cystic epithelial cells may contribute to the greater expansion or enlargement of the cyst. So, these preformative cells of dental lamina are cause for the cell proliferation and formation of the cyst. Next, osmolarity of the cyst fluid. The average concentration of cystic fluid is usually higher than that of the blood serum, which could be due to the presence of large amount of soluble protein and cell breakdown products within the cystic fluid. Because of this, there is a significant osmotic difference between the serum and the cystic fluid, which helps to draw more and more fluid towards the cystic lumen through the process of diffusion. Thus, there is increased hydrostatic pressure is built up between the serum and the cystic fluid, which causes resorption of the bone. The more and more fluid from the surrounding will be attracted into the cystic cavity. It leads to the more and more fluid accumulation into the cystic cavity, due to which the fluid accumulation causes the resorption of the bony structure, which results in expansion of the cyst. Enzymatic mechanisms. Increased collagenase activity. It is believed by some investigators that odontogenic keratocysts release considerable amount of an enzyme collagenase. This collagenase involves in breakdown of the organic structure of the bone, which contains mainly the collagen. Once the organic portion of bone is broken down, it leads to collapse of the bony structure. Further, the cyst can leads to the expansion. So these are the three basic mechanisms which leads to the cell formation, cyst formation in case of odontogenic keratocyst. Histological features. It presents few characteristic histological features, especially the odontogenic keratocyst. The wall of the OKC is usually rather thin, less than there has been any superimposed inflammation. The lining epithelium is highly characteristic. It is composed of parakeratinized surface, which is typically corrugated, rippled, or wrinkled. The corrugation is due to the unequal pattern growth of epithelium. a remarkably uniformity of the thickness of the epithelium, usually ranging from 5 to 8 cells thickness. These are the very common characteristic features of the epithelium, which is usually 5 to 8 cell layer in thickness, a prominent palisading and arrangement of the cells, polarized basal cells often described as picket fence or tombstone appearance. Point to be noted for Viva. Histologically, these cysts are formed with a stratified squamous epithelium that produces 10% orthokeratin, 83% parakeratin, and both the types of keratin in 7%. That is a mixed lesion. In the characteristic feature of odontogenic keratocyst being there are no any rete present of epithelium, neither the connective tissue papillae, like how in normal healthy epithelium they are present. Because of this, the epithelium often peels from the connective tissue in 94% of the time. As there is no any strong bond between epithelium and connective tissue, the epithelium is very fragile. The basal layer of epithelium is made up of tall columnar cells or cuboidal cells. Columnar cells are often associated with parakeratinized variant and exhibit palisading arrangement. Here, a picture on our right side showing the palisading arrangement of the cells, which usually is 5 to 8 cells layer in thickness, and there are no any rete formation in between epithelium and connective tissue. The cells contain intensely basophilic nuclei, which are situated away from the basement membrane. There is a presence of reverse polarity of basal cell nuclei. Sometimes the basal layer of epithelium is made up of cuboidal cells, and these cells are more often seen in association with orthokeratotic linings. The orthokeratotic cysts often exhibit abundant orthokeratin formation and a well-defined granular layer, which is a peculiar feature of orthokeratinized epithelium. The cells of the suprabasilar layer of epithelium are polyhedral in nature and often exhibit intercellular edema. This is nothing but the accumulation of the fluid in between the cells. Mitotic activity is seen in both the basal as well as suprabasal layers, but in most frequent in the suprabasal layers compared to the basal. It is higher in odontogenic keratocysts occurring in association with nemoid basal cell carcinoma syndrome. Large amount of desquamated keratin is often found within the cystic lumen. The junction between the cystic lining and the connective tissue capsule is weak. You can see here. And in many cases, the cystic epithelium may be detached from the underlying connective tissue. One of the most interesting histopathological feature of odontogenic keratocyst is the presence of multiple small microcysts within the connective tissue. These are known as daughter cysts or the satellite cysts. Besides satellite cysts, connective tissue wall also exhibit proliferating remnants of the dental lamina. In syndrome-associated odontogenic keratocyst, the lining epithelium is considerably thicker and exhibit nests of basaloid cells budding off from the cystic lining. The cystic epithelium of odontogenic keratocyst sometimes shows the dysplastic changes and very rarely it shows the malignant transformation. The fibrous capsule is usually thin and devoid of inflammatory cells. It also shows hyalinization, melanin pigmentation, mucous metaplasia, and hyaline bodies, sometimes presence of cholesterol. In cases of intense secondary inflammation, the epithelial lining of the cyst often loses its characteristic features and therefore looks like a lining of the radicular cyst. This is the characteristic histopathological picture of an odontogenic keratocyst, where you can see the epithelial lining is uniformly thin. This is the epithelial cystic lining, which is uniform. almost everywhere, and it is quite thin. Generally, it ranges from 5 to 8 cell layers thick. The basal cell layers, which are tall columnar, exhibiting palisaded pattern with the polarized nuclei, that is nuclear away from the basement membrane, and intensely stained. The luminal epithelial cells are parakeratinized and produce the corrugations. These are called as the corrugations, which are unequal in growth. Dentinoid formation is an unusual finding with the OKC. This could be due to the inductive effect of the odontogenic epithelial component. The electrophoretic measurement of fluid from the cyst has been shown to contain very low content of soluble protein compared to patient's own serum. Just a glance for you all, what is nemoid basal cell carcinoma syndrome? It is a hereditary disease and inherited as autosomal dominant trait, presents with the characteristic clinical features such as multiple nemoid basal cell carcinomas of the skin, multiple odontogenic keratocysts of jaws, bifid ribs and abnormalities in vertebrae, ocular hypertelorism and broad nasal root, frontal and parietal bossing with enlarged head circumference, CNS disturbances with calcifications of Hox cerebri and abnormal shape of the sella turcica, epidermal cysts of the skin, cleft lip and palate in few cases. Once we know the cause, what is the cause for the odontogenic keratocyst, how the cyst formation occurs, what are the clinical features and the radiographical features, the confirmation of the cyst is only conducted by performing a biopsy of the lesion. Once it is confirmed, the treatment and the prognosis will be as follow. The cyst should be surgically excised. However, clinical experience has shown that the complete eradication of the OKC may be difficult because the wall of the cyst is very thin and fragile, may easily fragment. In addition, perforation of cortical bone, particularly in lesions involving the ramus, is common, and this complicates the removal. The most important feature of OKC is recurrence. Very commonly asked, what are the causes for recurrence of OKC? Its rate being 13% to 60%. It is observed that recurrences were more frequent, around 63% with the cyst involving nevoid basal cell carcinoma syndrome, keratocysts, than without the syndrome, that is 37%. Keratocysts enucleated in one piece recur significantly less as compared to keratocysts enucleated in several pieces. It was also reported that OKCs in the mandibular region, angle or ascending ramus had high recurrence rate. This could be probably due to the chances of epithelial rest will be left behind after the surgery, owing to its limited surgical access to the posterior part of the mandible. The size of the lesion did not seem to influence the prognosis after the surgery, whether it is small or large. But those whose radiographic appearance was multilocular had a high recurrence rate. There is no significant difference in recurrence rate following three basic methods, whether the patient treated with the marsupialization, enucleation, and primary closure, then enucleation and packing open. Furthermore, recurrence does not appear related to the presence of the satellite cyst. On this basis, it is considered that the recurrence of the keratocyst is the nature of the lesion itself. That is the presence of additional remnants of the dental lamina from which cyst may develop. Since recurrence may be long delayed in this lesion, so the follow-up of any of OKC case annually with a radiograph, at least for successive 5 years after the surgery, is a mandatory. It is also essential that patients with an OKC, especially if multiple, be evaluated medically to rule out jaw cyst basal cell nevus bifid rib syndrome. So these are the all factors to be taken into consideration during the treatment. Coming to the main factor in odontogenic keratocyst, the causes of recurrence. What are the causes of recurrence? Satellite cyst, new cyst formation, keratinization pattern, nature of the cyst lining, basal cell layer of epithelium, conservative surgical approach. These all factors together contribute to the recurrence of the odontogenic keratocyst. But how? Let's see. Satellite cysts. Satellite cysts, it is also called as daughter cysts, are the common entities in odontogenic keratocysts, and these small cysts often remain undetected within the tissue during the treatment. The higher rate of recurrence in keratocysts could be due to the enlargement of the satellite cysts following the treatment. So this is the one factor, contributing factor. New cyst formation. The cells of the odontogenic keratocyst have an aggressive potential for multiplication, and this tendency may often cause formation of new cysts in jaw, which often appears to be the cause of recurrence. If any part of the cyst capsule remains within the bone during surgery, the retained part of the capsular tissue of the cyst may lead to the recurrence due to multiplication and subsequent cystification of those epithelial remnants. Keratinization pattern of the cystic epithelium. Odontogenic keratocysts, which have a parakeratinized epithelium, often have a more possibility of recurrence. Nature of cyst lining. The lining of odontogenic keratocyst is thin and fragile, and therefore it is very difficult to enucleate the entire lining of large cysts during surgery. Thus, if some portion of the lining left behind within the bone could result in further cyst formation. The odontogenic keratocysts grow fast, but as the bony expansion is too little, the size of the cyst is always smaller than what is expected. The narrow infoldings or finger-like projections extended deep into the cancellous bone up to variable depth. During the surgery, these narrow infoldings are easily left behind the corrugations, therefore increasing the risk of recurrence. Basal layer of epithelium. New keratotic cysts may sometimes develop from the basal cell layers of the epithelium. The conservative surgical approach, in an attempt to save the vital surrounding structure surrounding the cyst, sometimes conservative surgical approach is undertaken. It results in incomplete removal of the cyst, leading to its recurrence. So these are the factors which contribute to the recurrence of odontogenic keratocyst. CM Dental Academy has designed a oral pathology and microbiology module for third BDS students. The highlights of the course being online live lectures, session recording access, targeted revision at the end of the module, online notes, viva voce points and MCQs, important slides will be discussed, and free library access. So what are you waiting for? Grab the opportunity and book your slots. Already the courses have commenced from 1st June. Thank you.